Hello everyone, my name is Erick Gonata with 3 digit of my student ID is 096. I will present about the background of our student project. So, intrauterine growth restriction or IUGR is a complex obstetric problem that affects approximately 10 to 15% of pregnant women worldwide. It is also associated with significant perinatal morbidity and mortality. IUGR itself is defined as a fetus that fails to achieve its growth potential, while antenatal small for gestational age or SGA is defined as a fetus with weight less than 10th percentile. In medical world, the terms IUGR and SGA are commonly used interchangeably. The identification of IUGR is crucial and begins with the assessment of risk factors itself. The diagnosis is made by ultrasound using biometry when this confirms an estimated fetal weight or of less than 10 percentile. The common risk factors include maternal causes, which are hypertension, diabetes, cardiopulmonary disease, anemia, malnutrition, smoking, and also drug use. And also we got fatal causes, which are genetic disease, including aneuploidy, congenital malformations, fatal infection, multiple pregnancies. And also we got the placental causes, which are placental insufficiency, placental infarction, and placental mosaicism. IUGR is also associated with increased risk of development in adult life of metabolic disease, including but not limited to hypertension, diabetes, obesity, dyslipidemia, and the metabolic syndrome. The student project will dive deeper into the causes, effects, the potential treatments and preventions, as well as the prognosis of this topic.
Thank you for the opportunity. My name is Geg Mas Anantalakshmi with the last digit of NIM number 001. Today, I'll explain about our student project problem formulation. First, what is the definition of intrauterine growth restriction? Second, what is the epidemiology of intrauterine growth? Sama. Nah, Oke, take 4. Thank you for the opportunity. My name is Geg Mas Anantalakshmi with the last digit of NIM number 001. Today, I'll explain about our student project problem formulation. First, what is the definition of intrauterine growth restriction? Second, what is the epidemiology of intrauterine growth restriction? Third, what is the etiology of intrauterine growth restriction? Fourth, how is the pathophysiology of intrauterine growth restriction? Fifth, what is the clinical presentation and diagnosis of intrauterine growth restriction? 6. What is the prognosis of intrauterine growth restriction? 7. What is the management and prevention of intrauterine growth restriction? The next topic will be explained by my colleague.
Hello, my name is Marta, and my last digit of student number is 064. Now I'll talk about the objectives of this paper. So first, to describe the definition of intrauterine growth restriction. Second, to explain the epidemiology of intrauterine growth restriction. Third, to explain the etiology of intrauterine growth restrictions. Fourth, to explain the pathophysiology of intrauterine growth restriction. Fifth, to describe clinical presentation and diagnosis of intrauterine growth restriction. Six, to explain the prognosis of intrauterine growth restriction, and the last is to describe management and prevention of intrauterine growth restriction. And we hope through this paper we can receive the benefit, which is first to provide new understanding and insight about intrauterine growth restriction, and understand the prognosis, treatments, as well as preventive measures for intrauterine growth restriction. That's all from me. Thank you.
Hi, my name is Caitlin with the 3 digit last number is 138. I'm going to explain for the definition of intrauterine growth restriction, or IUGR. IUGR is described as fetal development that falls below the expected pace and potential growth for a particular newborn, depending on the fetus's race and gender. Although there is a distinction, the terms small for gestational age or SGA and IUGR have been utilized synonymously in scholarly works. Regardless of the birth weight percentile, IUGR, as stated before, is a medical term indicating a newborn who has diverged from the intrauterine growth curves and is born with symptoms of undernourishment and impaired development in utero. Therefore, even if a newborn has appropriate anthropometric measures, they may still be classified as IUGR if they show indications of malnutrition at birth and indicators of in utero growth slowing impairments such as irregular Doppler flow. On the other hand, newborns classified as SGA have the weight at birth at least 2 standard deviations lower than the population's average and falls below the 10th percentile for the particular gestational age. That is all I can say. Thank you.
Hello everyone, my name is Natania Sutedja with real last digit of student number 175 and I'm going to explain about the epidemiology of intrauterine growth restriction. Intrauterine growth restriction is a serious public health issue, particularly in nations with limited resources. In wealthy nations like United States, the prevalence of this exceeds 10%, with one-third of these instances being intrauterine growth restriction. Conversely, it is projected that intrauterine growth restriction rate in under-resourced nations are 6 times greater than those in well-resourced nations. In non-Western world, intrauterine growth restriction affects around 30 million children annually. Of these, infants in Asia account for 75% of cases. Despite uncertainties around small sample of preterm newborns, a cohort research conducted in Tanjung Sari, Indonesia, revealed that 35% of infant mortality occurred among non-intrauterine growth restriction kids and 48% among intrauterine growth restriction babies. At 1 year, the cumulative survival rate was close to 95%, and first 3 months had the highest change of that. That's all from me. Thank you very much.
Next, I will explain about the etiology of intrauterine growth restriction. But before that, let me introduce myself. My name is Putu Indriati with last street number 231. The exact cause of IUGR can be challenging to pinpoint and it may often remain uncertain. However, several identifiable risk factors and potential causes have been recognized. Among these, issues with the placenta, which is responsible for supplying the fetus with nutrients and oxygen, are common. Maternal medical conditions, including but not limited to diabetes or hypertension, can also contribute to IUGR. Autoimmune disease, multiple pregnancies, exposure to environmental toxin is another contributing factor, and additionally, genetic factors may play a role in this condition.
Hello, my name is Pande Putu Candra with my last 3-digit number R240, and now I'll present you about the topic 2.4 pathophysiology. So, intrauterine growth restriction can be caused by placental insufficiency, which is a condition where the placenta is unable to provide adequate nutrient and oxygen to the fetus. Fetal abnormalities including genetic disorder, chromosomal abnormalities, and congenital infection can also contribute to intrauterine growth restriction or IUGR. Thank you.
Hello, doctor and friends. My name is Geraldine with the last 3 digits of student ID is 100, and I'm going to present the clinical presentation of IGR. So the clinical presentation of IGR depends on the underlying cause. Patient may experience abdominal pain due to placental abruption or headache, visual disturbance, and epigastric pain due to preeclampsia. Typical clinical findings of suspected IGR include first, loss in abdominal circumference and or estimated total weight. Second, decreased symphysis fundus in proportion to gestational age at least 3 cm less than gestational age in weeks. Third, small fetus for its gestational age and reduced or absent fetal movements. Fourth, increased head circumference to abdominal circumference ratio in asymmetrical type of IGR, and last, presence of oligohydramnios without ruptured membranes. That's all from me. Thank you.
Hello, my name is Sabrina, and I will continue the explanation. It's about the diagnosis. So, diagnosis of intrauterine growth restriction is done by accurately measuring dating and various influences of risk factors. Intrauterine growth restriction occurs when the fetal weight measurement is under 10% at gestational age, calculated by biometric measurement. First, we start calculating the date of delivery, continue to take anamnesis on the patient to find out the risk factors that affect fetal growth. Uncontrolled systemic disease such as hypertension, kidney disease, and diabetes play a major role in causing IUGR. Then there are various screening. We can use in serum analyte screening, uterine artery Doppler, and the SFH. Thank you.
Greetings, my name is Sutedja Karuniaputri with Related Students number 235. Now we're on last subtopic in this student project talking about IUGR or intrauterine growth restriction. Preterm does have more complication with a high mortality rate when it occurs. Even though the LBW or low birth weight is the one determine the level of safety, in fact, it's still hard to diagnose. The mortality of children who have given birth with IUGR reaches figure of up to 61.2%, and dominantly in their 90 days, since it's their vulnerable age period or with low birth weight, touches into 1% percentile or abnormal Doppler, which is a placental insufficiency markers. If the IUG are detected before the 32 gestation and the labor happens, it will give a worse outcomes. For deliver the baby, there's no correlation between the methods, which should be SVD or spontaneous vaginal delivery or cesarean. When the baby is survived, the health program should target weight gain to baby with good nutrition for their survival, which can decrease the mortality rate into 60%, and also should be monitored since the complication outcome has arisen such as perinatal asphyxia, hypothermia, hyperglycemia, jaundice, feed intolerance, and also can lead up to neurobehavioral abnormalities. That's it from me. The next topic will be brought by my friends. Thank you.
Hello, my name is David Christopher Chandra with the name 066. I would like to explain about the management and also the prevention of FGR. Start with the management. So the initial approach to manage FGR involves addressing factors that impede growth and creating a conducive intrauterine environment to optimize fetal growth and development. This includes improving maternal nutrition, avoiding harmful substances, and also managing maternal health conditions. So pregnancies with FGR face challenges in antepartum surveillance due to high-risk conditions and varied methodologies. A recent review found that NST didn't significantly impact perinatal mortality or morbidity. Ultrasound may reduce interventions and lower morbidity in FGR pregnancies. So a study group has developed a stage-based protocol for managing FGR that focuses on categorizing indices or signs associated with similar fatal risks. So this categorization allows for the establishment of consistent follow-up intervals and optimal timing for the delivery. So here are the stages. The first stage is defined by abnormalities in the uterine artery, UA, MCA Doppler, or CPR, with a low risk of fetal deterioration before term. The second stage is defined by abnormalities in the UAADV, with delivery recommended after 34 weeks. The third stage is defined by reverse diastolic flow in the UARADV or DVPI above 95th centile, with a high risk of stillbirth and poorer neurological outcome. And stage 4. So reverse arterial flow in the DV Doppler, decreased short-term variability in the CCTG, or spontaneous FHR decelerations are the indicators of the stage 4 of FGR.
Hello, my name is Gusti Saraswati. My last three digit number 056. Now I will explain about prevention. Routine pregnancy check to monitor the baby growth and development, detect potential problem early, avoid tobacco and alcohol, maintain a healthy diet, regular exercise. If the mother has chronic healthy conditions such as diabetes or high blood pressure, it is important to treat the mother problem to prevent complication. Regular ultrasound and avoid contact with sick people. That's all for me. Thank you.
My name is Zephania Ekklesia, and my last three digits of my student ID number is 127. To conclude, IUGR is retardation of fetal growth rate during pregnancy with signs of malnourishment or impaired development. Several factors correlates with IUGR, such as placenta abnormalities, maternal disease, multiple gestation, environmental toxins, and genetics. History taking and physical examination are both essential to make the diagnosis. IUGR in early pregnancies has worse outcomes. Early detection and immediate improvement of maternal nutrition are important in management of IUGR. We advise to perform maternal health screening in expecting mothers regularly, and conduct maternal health education to improve awareness about IUGR.